I'm proud to present our next speaker, Dr. Khalid Yusuf. Dr. Khalid Yusuf has accomplished the European Board and subspecialty exam in endocrinology and diabetes in MRCB. He is currently a tutor of postgraduate diploma in endocrinology in South Wales University. He is also the General Secretary of Egyptian Thyroid Association. He is a marvelous speaker, and he's going to address the next topic, which is the medical management of Graves' disease. So go ahead, Dr. Khalid.
Thanks, Prof. Tamer. Thanks, Prof. Alia. Thanks, Dr. سمير. بالطبع صعب جدا الواحد يتكلم بعد الدكتور سمير والدكتور علياء، والأصعب إن الدكتور تامر راح يتكلم بعدي، فالمهمة بتاعتي صعبة بصراحة. but I will try. وزي ما اتعلمنا من الدكتور سمير والدكتور علياء والدكتور تامر guidelines evidence based medicine، اتعلمنا من الكارديولوجيست والأكثر مع الاندوكراينولوجيست. الجايدلاينز مهمة كتير. الجايدلاينز بتحط لنا الخطوط العريضة اللي لازم كلنا نمشي عليها. And today, inshallah, in my presentation, I will discuss in just a few recommendations from the American guidelines published in 2016 about the management of hyperthyroidism, and also the guidelines published by the European Thyroid Association about the management of Graves' hyperthyroidism. This is very important two guidelines. Let's start from the goal of the treatment. Any treatment for Graves' disease, the main goal is to render the patient euthyroid as quickly and safely as possible. ازاي نعمل القصه دي؟ by normalization of thyroid hormone and TSH, and also by correction of clinical signs and symptoms and metabolic derangement. We have three options for management of Graves' disease: الميديكال ثيرابي، and بالطبع الراديو-اكتيف ايودين ابليشن ثيرابي، واللي اتعلمناه واستفدنا كتير من محاضره استاذتنا الدكتوره علياء، ومتوقع ان الراديو-اكتيف ايودين الناس كتير تبدا تكتبه بعد المحاضره الرائعه. والسيرجري the last option or the third option. وطبعا رايحين نستمتع بمحاضره الدكتور تامر about السيرجري. الثلاثه اوبشنز دول بيختلفوا في الميكانيزم في انديوس ايوثايروديزم. احنا في النهايه الهدف من الميديكال من التريتمنت اوف جريفز ديزيز is to render the patient euthyroid. الميديكال ثيرابي في النهايه راح decrease الثيرويد سينثيسيس، الثيرويد برودكشن، الثيرويد هرمون برودكشن. الراديو اكتيف ايودين ابليشن اور سيرجري will decrease الثيرويد تيشو ومن ثم الثيرويد هرمون. الافيكاسي بتختلف من طريقه للثانيه، السيفتي، الكونفينينس اند الكوست. في النهايه في كل الجايد لاينز في كل الكتب اللي بتتكلم عن 3 اوبشنز بتحط 3 اوبشنز فور مانجمنت اوف جريفز ديزيز، وكل واحده ليها مزايا وكل واحده ليها عيوب، كل واحده ليها كيوراتيف ريت بطريقه معينه بتختلف. عشان كده الصعوبه بتاعت المانجمنت اوف جريفز ديزيز ازاي تختار الوسيله الامثل للمريض اللي قدامك. مفيش طريقه ينفع نعممها ونقول كل المرضى بتوعنا لازم ياخدوا ميديكال ثيرابي از فيرست اوبشن. ما ينفعش اقول ان كل العيانين نبدا بالراديو اكتيف ايودين. في النهايه في ادفانتج اند ديس ادفانتج بتاعت كل واحده من دول، وفي النهايه في need for lifelong thyroid replacement في بعض الطرق. في بعض الطرق ما بتحتاجش القصه دي، في بعض الطرق الريميشن is very high، وبعض الطرق في complications of surgery and so on. عشان كده لما اتعملت احصائيات كتيره world wide انهي فيرست الناس تستخدم how to manage uncomplicated case of Graves' disease، معظم دول العالم ريكومند الميديكال ثيرابي as a first choice. تقريبا world wide 93.9 ريكومند الميديكال ثيرابي الانتي ستيرويد دراجز. ولكن ما ننساش ان في USA ونورث امريكا زي ريكومند الراديو اكتيف ايودين ابليشن as a first choice in uncomplicated Graves' disease. السيرجري still worldwide the last option for management of Graves' disease. بس ما تنساش ان في بعض المرضى السيرجري نختارها رقم 1، مرضى ثانيه الراديو اكتيف ايودين رقم 1، ولكن worldwide as a general concept الميديكال ثيرابي is still as first choice. النهارده انا رايح اتكلم عن جزئيه الميديكال ثيرابي، ولازم نكون متفقين مين المريض اللي احنا بنفضل له ياخد ميديكال ثيرابي. clinical situations that favor anti-thyroid drugs. رقم 1 patient with high likelihood of remission. مشكله الانتي ثايرويد دراجز worldwide عموما
Dr. Khalid, excuse me, can you please stick into English because we have non-Arabic speakers, okay, attendees, please?
Okay.
Thank you.
Yes, okay. So we must know that anti-thyroid drugs have a high rate of relapse after treatment. So you need to select your patient and to choose who will have high likelihood of remission. And this will be discussed later, inshallah. Another one in which we favor anti-thyroid drugs is pregnancy and also the elderly or others with comorbid increasing surgical risk or limited life expectancy. Individuals unable to follow radiation safety regulation, as mentioned by Prof. Dr. Alia, patient with previously operated or radiated necks for another cause. So in this patient, the surgery is not preferred, and also radioactive iodine is not preferred as a first option. Patient with lack of access to high volume thyroid surgeons or patient with moderate to severe active graves of salmopathy. In these situations, the anti-thyroid drugs is the preferred option. So in all recommendation, in all guidelines, they put table like this: who we will prefer radioactive iodine and who we will prefer anti-thyroid drugs. For example, if there is a liver disease, an anti-thyroid drug is not the first option. A radioactive iodine is the preferred, surgery is the next one, and the anti-thyroid drugs is the last one because it can affect the liver. For example, in the active graves of salmopathy, active graves disease, radioactive iodine is not preferred as the first choice, and the anti-thyroid drug is the first choice. Surgery is also an alternative treatment. So for the medical management of Graves' disease, we have two options. The first one is symptomatic treatment by using of beta blocker. For example, a tremor, tachycardia, palpitation can be treated just by beta blocker. And another one to decrease the thyroid hormone senses by using anti-thyroid drug. So let's go to the symptomatic management, and according to the guidelines published by the American Thyroid Association, they recommended beta blocker to be used in every patient with symptomatic thyrotoxicosis, especially in the elderly and thyrotoxic patient with resting heart rate more than 90 beats per minute or coexisting cardiovascular disease. So in elderly patient, if the heart rate is more than 90 beats per minute or there is coexisting cardiovascular disease, we need to use beta blocker for rate control for symptomatic management. Of course, beta blocker is a lot of beta blockers, but propranolol is the most widely, and we have a long experience about propranolol. You must know that the dosage of propranolol is 10 to 40 milligram to be used 3 to 4 times per day. Don't forget that propranolol is the best beta blocker used during lactation and during the pregnancy. Another one, which is atenolol, which have a long half-life than propranolol, so can be used once or twice per day. Don't forget that atenolol should be avoided during the pregnancy. For every patient who cannot tolerate the beta blocker or contraindicate to use a beta blocker, we can use a calcium channel blocker, verapamil or diltiazem, as an alternative for beta blocker. This is just for a few weeks. Just after rendering our patient is euthyroid, we can stop these drugs. Another one, don't forget that in the 1942 Ashwood, working in the Harvard University and Tufts Medical School, treats the first hyperthyroid patient with thiourea. After this year, by 5 years, the FDA is approved the propyl thiouracil. After 2 years, the FDA approved the mesimazole, and the carbimazole is approved after 4 years of that. Since that time, no antithyroid medication is discovered. We have only these 3 medication. So cyanamide, carbimazole, mesimazole, propyl thiouracil. Don't forget that mesimazole is the active metabolite of carbimazole. So when we speak about carbimazole, the same concept about mesimazole. Carbimazole is converted, decarboxylated in the liver to mesimazole. The main difference between these 2 drugs is the effective dose or equivalent dose. For example, 10 milligram of carbimazole is converted to 6 milligram mesimazole in the liver. So when we speak about the mesimazole, the same that we speak about the carbimazole. when we compare between الميثيمازول or carbimazole with propylthiouracil, the half-life of propylthiouracil is short, but of methimazole is long. So the duration of action of methimazole is prolonged more than 24 hours, so can be used once daily dose, but the propylthiouracil must be divided into 2 or 3 doses per day. Both drugs cross the placenta, but the methimazole cross more than propylthiouracil. Effect of 5-deiodinase, of course, the methimazole has no effect on 5-deiodinase in comparison. Propylthiouracil block 5-deiodinase, so prevent the conversion of T4 to T3 in the peripheral tissue, and can be used in the management of thyroid storm by this mechanism. Both drugs are excreted in the kidney, and adverse events is more with the propylthiouracil. Time to achieve euthyroidism with the methimazole is within a few weeks, but with the propylthiouracil within few months. The compliance with methimazole and carbimazole is more than propylthiouracil. Factors associated with a higher likelihood of immunological remission following the course of antithyroid drugs. Don't forget this when you choose your patient who will start with antithyroid drugs. You must choose your patient. The patient who have suspect likelihood of high remission is a female, age more than 40 years, small goiter, mild hyperthyroidism, low TSH receptor antibody TRAB, or high TPO antibody positivity. If you face a patient with this criteria, you must suspect a likelihood of remission rate is more than 50%. So let's start by what is the contraindication of antithyroid medications. Previous severe side effects to the drug is absolute contraindication. Another one, which is recommend the propylthiouracil and does not recommend the methimazole in the first trimester. In the early pregnancy, you should use propylthiouracil, not methimazole or carbimazole. But you must know that the propylthiouracil and methimazole, both drugs are teratogenic, both effect, but the propylthiouracil is less teratogenic. The most common side effects by carbimazole for the fetus is aplasia cutis and esophageal atresia. This is a very rare complication, but it is more with methimazole than propylthiouracil. What is the mechanism of action of antithyroid drugs? The 3 mechanism of action is very important. The most important one is inhibition of TPO. TPO is very important in the thyroid hormone senses, in coupling, in coupling of iodotyrosine in the iodine oxidation organification. So when we inhibit TPO, thyroid hormone production will be decreased. Another very important mechanism of action, this is a unique for propylthiouracil, inhibition of D1 and D2 deiodinase. So inhibit the conversion of T4 to T3 in the peripheral tissue, and for this unique advantage for propylthiouracil, it is used in the thyroid storm because we need a rapid action of a drug, and also we need prevention of conversion of T4 and to T3. Another effect of antithyroid drugs is thyroidal immunity, effects on the thyroidal immunity, either direct or indirect, and this will lead to, by using antithyroid drug, TRAB will be decreased after a few months of initiation of the therapy. And also by using of antithyroid drug after radioactive iodine, it will decrease an exacerbation of TRAB which occur after radioactive iodine ablation. Which drug? As we mentioned previously, we have 3 drugs: methimazole, carbimazole, and the propylthiouracil. Which drug to be used? Since about 10 years ago, we usually use the propylthiouracil in the children, in the lactating, in the pregnancy, in elderly, but nowadays it is different. Don't forget that 10 milligram of carbimazole is converted in the liver to 6 milligram of methimazole, so carbimazole and methimazole are the same. And also 10 milligram of carbimazole is equivalent to 100 milligram of propylthiouracil, but don't forget that propylthiouracil must be given in a divided doses, 2 or 3 doses. In 6th of April 2009, FDA published an alert about the propylthyracil. The FDA is notifying healthcare professionals of the risk of serious liver injury, including liver failure and death, with the use of propylthyracil in adults and pediatric patients. And after a few months of this date, the FDA put a black box warning about the propylthyracil that can cause severe liver injury. So from that time, all guidelines recommend methimazole should be used in virtually every patient who choose antithyroid therapy for a grave disease, with some exception. So in all guidelines, don't use the propylthyracil except in 3 situations. Carbimazole or methimazole is the first choice if you choose antithyroid drug. When we use propylthyracil, in only the first one, patient intolerant to methimazole or carbimazole. Patient receive carbimazole and after that give a minor side effects, non-fatal side effects. And this patient refuses radioiodine or surgery. In this situation, we can use propylthyracil as an alternative to carbimazole. The next one, during the first trimester or early pregnancy, to reduce the risk of severe birth defects. The third one, during the thyrotoxic crisis, to reduce T4 deiodination to T3 by deiodinase type 1. This is the only 3 conditions in which we can use propylthyracil. Don't forget that in the latest guidelines published by the American Thyroid Association, after first trimester, to change to carbimazole or to continue propylthyracil, they didn't recommend conversion to carbimazole or any recommendation about this. They fear from a risk of uncontrolled after control of propylthyracil, so they did not recommend conversion or against the conversion to carbimazole after the first trimester. Before initiation of antithyroid drug, you need to check complete blood count, liver profile, including bilirubin and the transaminase, because if the patient is leukopenia, antithyroid medications can precipitate and can cause a granulocytosis. So put it in your mind to check complete blood count and liver enzymes before starting antithyroid drugs. Treatment regimens for grave disease, we have 2 regimens in the management by antithyroid medication. The first one is dose titration regimen by using high dose of antithyroid drug till rendering the patient euthyroid after a few weeks or a few months. After that, we decrease the dose of antithyroid medications to about 5 to 10 milligrams of methimazole or carbimazole, for example. And after this small dose, we continue the dose till 1 to 1.5 years of treatment. The next treatment, which is not preferred nowadays, which is a block and replace regimen. In this situation, we use a high dose of antithyroid medication until the patient rendered euthyroid after a few weeks. If we continue this high dose, the patient will enter in the heterogenic hypothyroidism. So we add levothyroxine therapy, 100 microgram of levothyroxine to avoid the hypothyroidism. So in the block and replace regimen, the patient will have a high dose of antithyroid medication, and after 1 month, for example, we add a levothyroxine therapy in 100 microgram and titrated dose of levothyroxine to avoid the hypothyroidism. Why they choose block and replace previously? Because they think that block and replace have a high rate of remission than dose titration regimen, and they think that adding levothyroxine have a role in the remission. But nowadays, all trials mention that a remission rate is similar in the dose titration regimen and the block and replacement regimen. Both regimens have the same remission, but in the block and replace regimen, we using a high dose of antithyroid drug, so its side effects is more and more. And later, inshallah, we will discuss the side effects of antithyroid drug and a lot of side effects related to the dose of the medication. So if we use a high dose of medication for a long period, the side effects will be more and more. So block and replace regimen is not recommended in any patient except one patient during the pregnancy if there is a neonatal fatal thyrotoxicosis. In this situation, we can use block and replace, but don't put it in mind. Don't try it except in a high, in a very specific situation. Dose titration regimen, this is the accepted one. We use it routinely in every patient. Initial dose of antithyroid drug, don't forget that 10 milligram of carbimazole is equivalent to 100 milligram of propylsauracil is equivalent to 6 milligram of mesimazole. How to initiate the dose? The initial dose, mostly in mesimazole, 10 to 30 milligram. In the carbimazole, it is 15 to 40 milligram. In propylsauracil, it is 150 to 450 milligram. So this is the initial dose. How to choose the initial dose? By two parameters according to the biochemical parameters of the patient and the clinical severity of the disease. So if FRT4 is elevated more and more, choose a starting initial dose, a high starting initial dose. If FRT4 is a mild elevation in the patient of a grave disease, you can choose a smaller dose of antithyroid drug. This is a rough dosing guidelines. If FRT4 is elevated 1 to 1.5 above the normal, we can choose mesimazole in a dose of 5 to 10 milligram as initial dose. If FRT4 is 1.5 to 2 folds above the normal, we can choose a starting dose 10 to 20 milligram. If the FRT4 is 2 to 3 folds above the normal FRT4, we can choose a high dose of mesimazole 30 to 40 milligram. Don't forget that antithyroid drugs are more effective in blocking thyroid hormone production when the patient iodine intake is low. So it is recommended to advise your patient to decrease the diets and foods that have a high iodine intake before initiation of antithyroid drug. Let's go to how initiate an antithyroid medication in any patient with a grave disease. For example, if we have mesimazole, we will start by 10 to 30 milligram. Don't forget from the start that telling your patient that he needs a lot of visits, he needs a lot of lab tests, as many as 9 to 12 per the course of the treatment. We will start by initiating the dose, and after that, every 3 to 6 weeks, we should measure FRT4 and T3. Once the FRT4 and the T3 is normalized, we should decrease the dose of antithyroid medication by 30 to 50%. If you don't do this, decrease the dose, the patient will enter in iatrogenic hypothyroidism. The most pitfalls occur in this situation is ordering a TSH in a follow-up. Don't check TSH in the after initiating of thyroid medication in a short period. TSH will be suppressed for a long time, for several months after starting a therapy, and it is therefore not a good parameter for monitoring therapy early in the course. كلمة اتعلمتها وسمعتها من الدكتور تامر، الhypothalamic pituitary thyroid suppression needs a lot of time to recovery. Hypothalamic pituitary adrenal suppression need a lot of time to recovery. So in the near after starting an antithyroid medication, followed by your patient by FRT4 and T3. Another pitfall which occur a lot by measuring only FRT4. FRT4 is very important, but also T3 is very important, because in a lot of patients, the FRT4 will be normalized early and the T3 is still persistent elevated. In this situation, the patient is still thyrotoxic. Don't reduce the antithyroid drug according to the FRT4 only. Only reduce the antithyroid medication after normalization of FRT4 and the T3. After that, repeat until normalization of TSH. After normalization of the TSH and of course thyroid hormone, you will decrease anti-thyroid medication till the maintenance dose. The maintenance dose of mesimazole is 5 to 10 milligram per day. The maintenance dose of carbimazole is 10 to 15 milligram. And also the maintenance dose of propylsauracil is, if used, is 100 to 150 milligram per day in divided doses. After that, we can follow our thyroid indices every 3 months. Don't forget, as we mentioned previously, mesimazole and carbimazole cover 24 hours. So you can give the all dose of mesimazole and carbimazole as a single daily dose. But when we split the mesimazole dose or carbimazole dose, if you start by a high dose of mesimazole or carbimazole, you can divide it into a twice daily dose, because this splitting for this dose will lead to effective TPO blockade for a full 24-hour period. This is very important when to split the mesimazole or carbimazole dose. If it is more than 20 or 30 milligram, it is preferred to be divided into 2 equal doses. But if you have a maintenance dose 10 or 15 milligram, it is better to be given once daily for a compliance. The duration of anti-thyroid drug therapy for a grave disease, it is recommended by all guidelines to continue for approximately to 1 to 1.5 years. Then discontinue if TSH receptor antibody and the TSH is normalized at that time. Let's start to this very important algorithm published by the European Thyroid Association guidelines for management of Graves' disease. In any patient with untreated Graves' disease, recent onset for adults and children, you should choose mesimazole or carbimazole as the first option. The duration of the therapy for adults is 1.5 years. For children, it is 3 years of therapy. And of course, you can choose if the patient accepts this situation, radioactive iodine or surgery as a first option according to the personal decision, or if the patient cannot tolerate mesimazole or there is non-compliance for a drug. A radioactive iodine is preferred if there is a small goiter, there is no or inactive graves of salmobasis. Surgery is preferred if there is a nodules or goiter, large goiter or active graves of salmobasis. After this duration of period, after 1.5 years for adults or 3 years for children, we must check TSH receptor antibody. If it is positive, we have 3 options. The first option is continue anti-thyroid medication for another 1 year. Another option is to go to definitive therapy by radioactive iodine ablation or surgery. The third option is long-term low dose of mesimazole. This is a very important option, and of course, American Thyroid Association in the guidelines, they also recommend this long-term low dose mesimazole for the patient who prefer this approach. If the patient continue mesimazole for another 1 year after 1.5 years for adults, we must check TSH receptor after the end of this period. If it is negative, we can stop mesimazole and ممكن تتوقع ان الريميشن is high. But if TRAB is still positive in this situation, remission is very low, relapse is very high, and in this situation, you need to go to radioactive iodine or surgery. The last option for our patient is the relapse. If the patient receives anti-thyroid medication and we stop it after the complete our course, after stopping mesimazole, and then there is a relapse of a Graves' disease. In this situation, we have 2 options: definitive therapy by radioactive iodine ablation or surgery, and another one by using long-term low-dose mesimazole. And this is very important, and it is, we must discuss it in more details with our patient, because they'll follow up the side effects, and of course the side effects is less and less after these months of therapy. Don't forget that the relapse after antithyroid drug, for every 10 patients, only 4 patients will cure after antithyroid medication. So a relapse rate is about 50 to 60%. This is a very high relapse rate, but it is acceptable. Factors that increase the risk of relapse after withdrawal of antithyroid drug: childhood, large goiter, severe thyroid dysfunction and diagnosis, short duration of therapy, active orbitopathy at the end of treatment, the presence of TRAB positive, active smoker, high iodine intake, postpartum period. This criteria will make a relapse high and high. So let's go to the side effects of antithyroid drugs. This is very important because 1 out of 4 patients receiving antithyroid drug will drop due to the side effects. The side effects can be classified into minor side effects like a rash, itchy skin, nausea, taste, food may taste differently. This is a minor side effects, and another fatal and major side effects which recommend to stop the medication. All guidelines recommend that before starting antithyroid medication, we must inform our patient about side effects, and this information should be in the writing. This is very important. And of course, as we mentioned previously, the side effects with the propylthyracil is more than the methimazole. Don't forget that granulocytosis, which is a fatal side effect, is a dose dependent in methimazole. So if we use a small dose of methimazole, granulocytosis is very, very, very rare. But with the propylthyracil, it is idiosyncratic. It is not dose dependent. Also, ANCA vasculitis is more common with the propylthyracil. Hepatotoxicity is hepatocellular with the propylthyracil, but it is a cholestatic jaundice with the methimazole. Most of side effects is a minor side effects in the form of pruritus, rash, arthralgia, fever, sore throat. But the major side effects is very, very rare in the form of granulocytosis and hepatotoxicity and aplastic anemia and vasculitis. Minor side effects in the form of skin rash, urticaria can be managed by antihistaminics. But if the patient is not improved after starting antihistaminics, you can change to another medication. Like if you start by methimazole, you can go to propylthyracil if the patient refuses radioactive iodine surgery. There is a cross reactivity for rash with alternative drug about 30 to 50%. So it may be occur with another drug. A granulocytosis. Once you suspect a granulocytosis, you must stop antithyroid drug and do differential blood count. A granulocytosis means a granulocyte or a neutrophil is less than 500 per million. The frequency is very rare. It is more with methimazole than propylthyracil. No dose relationship with propylthyracil. It is a dose related with the methimazole. It is very uncommon with methimazole dose 5 to 10 milligrams. Typically occur in the first few months after initiation of antithyroid drug, almost always in the first 3 months of initiation of antithyroid drug. The mortality rate is about 10%. So the guidelines recommend once the patient complains from pharyngitis or fever, you must do differential leukocytic count. If a granulocyte is low, less than 500, this is a case of a granulocytosis. Factor leading to worse outcome in the elderly, lower granulocyte before starting the therapy, severe underlying comorbidity like renal failure or cardiac or respiratory disease. How to manage granulocytosis? Stopping immediate cessation of the antithyroid drug is the first choice. After that, hospitalization with a broad spectrum antibiotic, consideration of hematopoietic growth factor therapy, which is not available in our country. Another side effect, it is a very rare side effect, but it is important, hepatotoxicity. The propylthyracil can cause fulminant hepatic necrosis. It is fatal, need liver transplantation, and it is more common in the children. So don't try to choose propylthyracil in the children because the side effects is more in the children. Liver function and hepatocellular integrity must be checked in any patient receiving antithyroid medication presented by pruritus, rash, jaundice, light-colored stool, dark urine, joint pain, abdominal pain, bloating, because this manifestation may reflect hepatotoxicity. Due to the different hepatotoxicity profiles, the alternative drug could be tried in severely ill patient with mild to moderate hepatotoxicity. For example, if the patient receiving propylsulfuracil and complaining from the mild to moderate hepatotoxicity, we can convert him to carbimazole or vice versa. And of course, the guidelines does not recommend, there is insufficient information to recommend for against routine monitoring of the liver function test. Vasculitis is very rare, but it is more common with the propylsulfuracil. The risk appears to increase with the duration of the therapy, more common in the children. And once you stop the medication, vasculitis will be improved. A little of patient needing immunosuppressive therapy. The monitoring of the patient taking antithyroid drug, all guidelines have no sufficient evidence to recommend with or against routine monitoring. It is in practice. Also, liver function monitoring during antithyroid medication is not recommended routinely because there is insufficient evidence. The last portion in my presentation is subclinical Graves' hyperthyroidism. Subclinical hyperthyroidism must be diagnosed clinically, not by symptomatology. And don't forget, this subclinical hyperthyroidism is a persistent subclinical. That is mean we need to do another TSH within 2 to 3 months. Subclinical hyperthyroidism means low TSH with normal free T4 and normal T3. This is the definition of persistent subclinical hyperthyroidism. And we should classify it into 2 grades. Grade 1, which is a mild subclinical hyperthyroidism, in which TSH is between 0.1 to 0.4, and the grade 2 subclinical hyperthyroidism, in which TSH is less than 0.1. And this is a severe form of subclinical hyperthyroidism. What is the investigation? We need to detect the etiology of subclinical hyperthyroidism by doing thyroid scan in some patients, thyroid ultrasonography and Doppler ultrasonography, and may require a TSH receptor antibody. If a TSH receptor antibody is positive, so subclinical hyperthyroidism is due to the Graves' hyperthyroidism. Why we need to treat Graves' subclinical hyperthyroidism? Because subclinical hyperthyroidism, a risk of progression to overt hyperthyroidism is high. Symptoms of hyperthyroidism can affect the quality of life, can affect cognitive impairment or dementia in some patients. Also, subclinical hyperthyroidism can lead to adverse cardiovascular effects and can cause osteoporosis and increase the risk of a fracture. So, subclinical hyperthyroidism must be managed correctly. This is the last slide in my presentation. A treatment of endogenous subclinical hyperthyroidism due to the Graves' disease according to the European Thyroid Association guidelines. For a grade 1, if the patient is more than 65 years with heart disease or comorbidities, for example, osteoporosis, you need to treat this patient by mesimazole. If the patient is less than 65 years, you need to, if the patient is symptomatic, you can treat by just beta blocker. No rule for antithyroid drugs in this situation. If the patient is asymptomatic, you just observe and repeat thyroid function test within 6 to 12 months. This is for grade 1. This is the mild form of subclinical hyperthyroidism. Another one in the grade 2 subclinical hyperthyroidism due to the Graves' disease when TSH is less than 0.1. Don't forget that we repeat the TSH within 2 to 3 months to diagnose it a persistent subclinical hyperthyroidism. If the patient is more than 65 years, we have 3 options: mesimazole, radioactive iodine, surgery. But all guidelines recommend medical therapy as a first option. If the patient is less than 65 years of age If the patient has a heart disease or another comorbidities, so we can treat by methimazole, radioactive iodine, or surgery. If the patient is persistent disease with symptoms and less than 65 years, the only option is to use methimazole or beta blocker for these symptoms. If the patient is asymptomatic, just observation and recheck thyroid function test within 3 to 6 months of duration. And all guidelines recommend the antithyroid drug should be the first choice for treatment of a Graves' disease due to the Graves' subclinical hyperthyroidism. And this is the last slide from my presentation. Thanks Prof. دكتور تامر، دكتور علياء، دكتور سمير لمشاركتي معاكم في الويبينار ده. شكرا جزيلا.